Right. Thank you very much, Dr. Kalebi, for that introduction. And of course, I would like to thank the organizers of the Kenya Crackon 2020. And the background to my talk is on pediatric mortality. And we know that currently pediatric pneumonia is the leading cause of death in the country, not just childhood death, but overall deaths. And there are many other causes of pediatric deaths. A lot of focus when it comes to the epidemiology of pediatric pneumonia focuses on the lungs. But today I'll discuss, in this discussion, you'll see that we'll need to look at the patient as a whole, and definitely renal medicine practitioners have an important role in managing these patients. So the PRESS study, as we call it, the Pediatric Respiratory Epidemiology Surveillance Study, the idea was to identify what are the causes of death due to pneumonias in our tertiary referral hospital. And during the study period, which was about 8 months in 2014, the surveillance arm screened 960 children who met the case definition for severe acute respiratory illnesses. And out of those, there were 230 mortalities. So you can see that the mortality rate is just above 20%. We managed to obtain consent for full diagnostic autopsy in 64 cases. And what surprised us, that in addition to a lot of the lung disease, which we expected, and of course was also surprising, there are also significant kidney diseases, and there are also other systemic diseases, most of which were not diagnosed clinically. And of course, if you look at the total number of deaths, 200 of them, the we were not able to contact quite a number of them, and some of them did not attend grief counseling. Just shows how difficult it is to perform these studies. 48% expressly declined consent, and in one, there was a problem with the storage. That's how we ended up with 64. So there was a strong attempt to get consent in all 200 of them. And if we look at the main findings, the characteristics of these children, most of them were aged below 11 months, with most of them being below the age of 6 months. Remember, we were recruiting those who are older than the neonate age group. So most of them were diagnosed. They will be classified as children, right? 2 months to 69 months. Comorbidities, congenital heart disease. Dr. Berger has just been discussing about cardiovascular disease, and earlier speakers have talked about cardiovascular disease. And indeed, cardiovascular disease is quite common in this population. And then, of course, there is prematurity. That is, they presented that as part of the history. Most of them presented because of cough and, of course, fever and vomiting. There are additional characteristics. I'm not going to go into the detail of this, but the majority of them, almost 90%, had malnutrition, and many of them required oxygen. So we performed the autopsies. I won't take you to the detail of the autopsy for obvious reasons. It's dinner time. But what we see is that eventually an autopsy only makes sense if there's post-mortem laboratory testing. And in the laboratory testing, we are interested in finding out the actual organisms. The main cause of death is the main infectious agent found was respiratory syncytial virus. And a lot of these individuals, there's a whole list of infections that we see, and there were mixed infections. So you can see that most of them had multiple etiologies. And this, we used multiplex PCRs. And this diagram shows that whenever we had multiple organisms, the most common organism that we came across was Pneumocystis jirovecii, meaning that we are dealing with individuals who have defects in cellular immunity. And this graph, which is very busy, shows the pathogens that we found, especially if you look at bacteria as an entry point. Okay, and here we can see that Klebsiella pneumonia present in more than 60% of these cases, and whenever we find Klebsiella pneumonia, there are multiple organisms. And of course, as I mentioned, if we have Klebsiella pneumonia in the lung, we could detect it also in multiple sites as well. Anyway, so today we're not here to talk about the lung disease or the infectious disease. I know you're interested in the kidney disease. Okay, for example, this is a picture of bronchopneumonia. These are gram stains identifying bacilli, and this is one case that had actually Klebsiella pneumonia and also had PCP, where we are seeing this in this GMS stain section, and also identified using immunohistochemistry to localize the pathogen to the specific site. And I'll mention that a bit later. And of course, the main diagnostic pattern that we came across is a necrotizing bronchopneumonia. But again, today is not a session for lung disease. The pulmonologists would like to spend, they will spend an entire hour on this. For example, when I get to this slide where we saw fungi, you can see aspergillus was also one of the organisms that we did see. And of course, tuberculosis and aspiration, which are not so common, surprisingly, because we expected a lot of it. So, of course, this study brought certain things, the difficulties of interpreting molecular microbiologic infectious disease testing, especially when you use multiplex PCRs. And we thought of certain variations related to postmortem interval. Now, I know the question you have is what is the relevance of all this information to renal medicine practitioners? One of the surprising things is that we found lots of kidney disease. We found what looked like an endocapillary proliferation in 67%, FSGS type lesions in 26%. What we thought was immune complex, though we didn't test it, we also saw some crescents. We did see vascular pathology in quite a number of them, and tubular interstitial disease, particularly proximal tubular necrosis in 34%, casts and interstitial nephritis were also quite common. So what we found is that a lot of these features were unusual, they were surprising, especially in the context of infection-related glomerular disease. For example, in this case here, we are seeing glomeruli here with increased cellularity and increased mesangial matrix. Dr. Kalebi, of course, don't like it much because we are not using PAS here. We were screening mainly using H&E. But we can at least see that this is definitely not a normal glomerulus. And if you look at the proximal convoluted tubule, we are seeing this focus of necrosis. So there's an ischemic type necrosis because it is focal. We are seeing it here. And when you look at some of these proximal convoluted tubules, maybe this one, there's a bit of simplification. And maybe this is a distal convoluted tubule. Another proximal convoluted tubule here, whose epithelium appears attenuated, meaning that it looks a lot more cuboidal rather than the expected columnar epithelium, showing that there's definitely acute tubular injury here. So in this slide, you can see that glomerular pathology and tubular pathology are coexisting side by side. We were also surprised to find cases of focal and segmental glomerulosclerosis, and in this one, it does appear somewhat nodular. So we had certain questions. We could also think of hyperglycemia-related disease, maybe an undiagnosed diabetic, and so on. And in certain children, we did find that there is global sclerosis and the tubular. You can see that all these glomeruli, if you stain, this is a Mason's trichrome stain. And if you have more than 50% of glomeruli with this kind of features, definitely this is chronic kidney disease in pediatrics that is definitely undiagnosed. So lots of glomerular features, which we hope to re-examine again at a later date because we have kept these tissues. FSGS type lesions in 18%, endocapillary proliferation in about 64%. Right. So of course, I've talked about ischemic acute tubular necrosis, and we've seen a picture of that, and I won't go into that. The other type of lesion that we did see quite a bit was tubular interstitial nephritis. And in this specific case, we are seeing an area where there are aggregates of lymphocytes forming what looks like a nodule. And in the center here, there's a large cell that appears to have an inclusion, most likely a CMV-related inclusion, and here it is. And our collaborators from the CDC actually used immunohistochemistry and identified that this was actually a direct infection with human herpes virus 4. Okay. So tubular interstitial nephritis is common in this population, and in some of them we did find intratubular casts with calcium, such as this. Okay, so there's intratubular calcifications, and you can see that there's proximal tubular injury with vacuolation. And this was a specific case of HIVAN. This was a child who was exposed to HIV. So major patterns, we've seen that 4% did have acute tubular necrosis, 21% had lymphocytic types of focal interstitial nephritis, and some had, we only saw 1% with eosinophilic TIN, and we thought that tubular interstitial disease is also quite important. There were also casts, and we did characterize some of the casts, most of them being hemorrhagic casts. The vascular diseases, so vascular pathology is also quite important. For example, in this individual, we are seeing that this is an arterial where there is thrombosis and foci of revascularization. Okay. And here is another arterial where we are seeing again, there's a thrombus and there's some degree of a concentric arteriolosclerosis, suggesting that there may have been hypertension in this, or hypertensive related vascular injury in this child. Okay. And of course, thrombotic microangiopathies, whose etiology we did not characterize. In a few cases, there was abuse, and in pediatric abuse, we do see injuries, especially to the lumbar region. And in this case, there was extensive injury to the lumbar region due to mainly traumatic injury with retroperitoneal hemorrhages. And here is hemorrhage into the interstitium of the kidney. And of course, we talked about casts. So there's a lot of vascular pathology, okay, not as much as the rest, but we are seeing about 12% of these children will have some type of vascular pathology. So the highlights of the systemic pathology is that 91% of all these individuals will have morphologic kidney disease, okay, kidney disease that we can identify on H&E. We haven't used immunofluorescence, we haven't used electron microscopy. So chances are that if we use those techniques, we could identify more, we could identify multiple disease. These children, 92% had malnutrition. The question is whether the malnutrition, especially malnutrition related to rickets and vitamin D deficiency, whether there's a relationship with the kidney disease, especially the CKD that we demonstrated earlier. And of course, we can treat these patients in isolation. They will have multiple pathologies in multiple systems. For example, I'm mentioning the bone marrow because one of my students, Dr. Bosire, identified hemophagocytosis, histiocytosis and hemophagocytosis in the bone marrow occurring in about 25% of these children. And we know that whenever there is that kind of a histiocytosis with phagocytosis, with erythrophagocytosis, then it's also related to all the cytokine storms that we've been hearing about related to COVID pathology. So there are lots of hypotheses we generate from this study. One, we are looking at developmental origins of health and disease and its impact on the kidney, especially diseases such as CKD, the relationship between prematurity and this disease. And then the question would be, if a child was admitted with a diagnosis of pneumonia, does it mean that as an adult they're likely to develop certain types of CKD? We need to look at that keenly because there is a preventive aspect to it in terms of preventing CKD in later life. and of course incorporating screening and diagnosis, and of course the unexplained kidney diseases that we do see in young adults in our country. Of course, there are unexpected findings, even as you're managing the kidney. If you're working in the pediatric sphere, always think of child abuse. Not so common, but when we saw it, it was grossly missed. It was missed by the clinical team, and there were very severe injuries, such as what you're seeing here in the brain. And I'm not going to itemize what you're seeing. Of course, severe malnutrition is something that we do see a lot in pediatrics. And a pediatric case like this will have a lot of many diseases, and of course, the kidney will have failed. And this is a child who's also likely to have glomerulosclerosis involving maybe 30–50% of the kidney of the glomeruli. And of course, systemic disease related to immune deficiency. This is the thymus of that child that I've shown previously. On the right is the thymus of a child who had a different cause of death. And you can see how severely atrophic the thymus is in these individuals who have severe malnutrition and perhaps chronic kidney disease. Okay, right. There are many questions we had um, about these cases, and we had to do a follow-up study because the question is, especially the organisms that we are seeing, could they be due to postmortem changes in terms of postmortem bacterial overgrowth? So we did a pilot study on 20 cases where we measured their core body temperatures, the core temperatures, correct rectal temperatures after refrigeration, and did serial testing to try and see whether um, the post-mortem process leads to overdiagnosis of certain infections. And of course, we were able to see a lot of these infections. We did this during one of the cold seasons. We started the study in July, so we do see a lot of adenovirus-related pathology here. And there was also a lot of malnutrition, so we are seeing CMV as well. And we were, if you look at these regression curves, is that if we plot the diagnosis that we made, a lot of them showed a lot of consistency in terms of a postmortem interval when you use a molecular technique, meaning that molecular microbiology techniques in autopsy are very stable. And I know the nephrology team will be interested in molecular diagnostic techniques, especially for heritable disease and studies involving CKD and so on. And we think it's feasible to use molecular techniques in the autopsy. So I have 3 conclusion slides. So in this conclusion slide, what I'd like you to take home is that when we look at pediatric severe acute respiratory illnesses, we see multiple pathogens. And there is lots of pathology in every system. So multidisciplinary approach should be important. The nephrologist has a role. There is usually seasonal variation. Right now we are in the midst of a pandemic. There's also something to do with that. Autopsies are feasible if there is good storage, and molecular studies are definitely feasible, and we may consider it for renal disease. As nephrologists, so nephrologists can support the autopsy by participating in the study designs and clinical pathology correlation. For example, we have just received ethical um, re, um, yeah, we have a go-ahead from our ethical committee to investigate COVID-19 mortalities among adults. And I'm happy to have within my team and one of the nephrology fellows, Dr. Joyce Bombengi, who was a co-chair in the previous session, where we intend to perform 250 autopsies in 4 Kenyan sites, which are 2 urban, 2 rural, and we also want to include one of the healthcare facilities. So the role of the nephrologist, of course, is not just in the conceiving the design, but also assisting in the clinical pathology correlation. As you've seen in this discussion, we've had a lot of, in our series, we do see a lot of things, pathologies that we do not know how to make sense of from the clinical perspective. And having the nephrologist there, because we'll be actively sampling the kidney, will be very important in the clinical pathology conferences. Right. So of course I have many people to thank, and I would like to thank Kiare once again for this. That is Dr. Bashir, who taught me in undergraduate, and I think also gave me one of my first jobs as well when I was a very young doctor. So for that reason, I'm very close to the nephrology team. I've worked with the pediatric team, and I'd be happy to also work with the adult team. So thank you very much, Dr. Kalebi. I hope I didn't go too much beyond my time.